I am Ann Slattery, the Managing Director of the Regional Poison Control Center at Children's of Alabama.
And I'm Justin Arnold, emergency medicine physician, toxicologist, and medical director at the Regional Poison Control Center of Children's of Alabama and the University of Alabama at Birmingham Department of Emergency Medicine.
We have nothing to disclose and no conflicts of interest. Our goals today are to discuss the need for naloxone training, review the 2015 Alabama House Bill 208, define and identify opioids, recognize signs of an opioid overdose, understand how naloxone works, and learn how to administer naloxone. So why are we here today? This is a map of the United States, and it's color-coded by the number of opioid prescriptions dispensed per 100 people. As you can see, there are 5 states in red: Oklahoma, Alabama, Tennessee, Kentucky, and West Virginia. And unfortunately, Alabama and Tennessee, at the time that this was done, tied as being the #1 states with opioid prescription dispensing. Also, when we look at drug overdoses versus motor vehicle deaths, as you can see, about 2007, drug overdose deaths far exceeded motor vehicles and continued to rise. In 2013, there were over 46,000 overdose drug deaths, and the DEA stated that over half of those were from prescription pain medications. Law enforcement officers, firefighters, and EMTs are increasingly being called to respond to opioid overdoses. Law enforcement officers are often the first responders on the scene. The timing of the administration of naloxone and rescue breathing is critical after an opioid overdose. House Bill, the 2015 House Bill 208, expanded naloxone use by limiting liability to prescribers, family and friends, and permitting law enforcement's use after training. It permits law enforcement to use naloxone intranasally, do patient assessment, and rescue breathing. So what is an opioid? An opioid can be a prescription pain medication, or it can be a street drug, an illicit drug. Opioids are substances that bind to specific receptors in the brain and decrease the body's perception of pain. Here are some generic and brand names of controlled substances which are opioids. We have buprenorphine, known as Suboxone. Codeine can be found in Tylenol No. 3. Fentanyl, most common brand name is Duragesic. We have heroin, which actually was a brand name from 1898 to 1910. It was used as a cough suppressant, but it is now an illicit drug. Hydrocodone, which can be found in Lorcet, Lortab, Norco, Vicodin. Hydromorphone, which can be found in Dilaudid. Levorphanol is a controlled substance we rarely see, but it is an opioid. Meperidine, which is Demerol. Methadone, which is Dolafine. Morphine, the most common one, is Roxanol. Opium. Paregoric is a liquid medication that is used for GI upset, and it has what's called the tincture of opium in it, which is anhydrous morphine. We have oxycodone, which you will see in Percocet, Percodan, and Tylox, and is the only ingredient in OxyContin. We have oxymorphan, which is Opana, and tramadol, which is Ultram and Ultracet. So what is not an opioid? There are other pain medications that do not work on the opioid receptors. Those are acetaminophen, which is Tylenol, ibuprofen, Motrin, naproxen, Aleve. Then we do have benzodiazepines, which are controlled substances and may mimic an opioid, but they do not work on that receptor. And that would be lorazepam, Ativan, diazepam, Valium, alprazolam, Xanax. Then we have our muscle relaxers, cyclobenzaprine, which is Flexeril, and methocarbamol, which is Robaxin. And of course, other drugs that people overdose on: cocaine, methamphetamine, PCP, which is phencyclidine, LSD, which is acid, Molly, MDMA, also ecstasy, and marijuana.
So let's talk about the signs of an opioid overdose versus a high. So a high from opioids, the person will remain awake but drowsy, and they'll respond to basic commands. Their breathing will appear relatively normal, not excessively labored, and not excessively shallow. They may have slurred speech and pinpoint pupils for the most part. In an opioid overdose, there are three primary findings that you'll find. First, the patients will have depressed mental status. Oftentimes, this means they're unconscious. They won't respond to any voice, any sternal rub or painful stimulus, and oftentimes their body appears limp. Secondly, they have depressed or absent breathing. You'll see that their breathing is shallow, oftentimes less than 8 breaths per minute, and this results in cyanosis. So their lips may appear gray, their skin may appear blue, and they may have dusky fingernails. If they have low oxygen for a prolonged period of time, their skin gets pale and their pulse can get slow and irregular. They can also have snoring, gurgling, or choking sounds as they try to breathe. This is commonly known as the death rattle. Thirdly, they'll have pinpoint or fixed narrow pupils. So what is naloxone? Naloxone is the generic medication for the commonly known brand drug Narcan. This is a rapid opioid reversal agent. So this is going to reverse the effects of any opioid medication. And what it does is it blocks the effects on the respiratory control center and therefore restores respirations to normal. It also blocks the effects on the brain and CNS depression and can restore a person to normal alertness. This picture shows what naloxone does, and as you can see, this is the same graphic from earlier. The opioid receptor is in the brain, the opioid is in pink, and the naloxone is in green. The naloxone will come and displace the opioid from the receptor, therefore reversing its effects. Now, it's important to note that naloxone is only useful for opioid overdoses. It will not work to reverse the effects of any drug or medication that is not an opioid or doesn't act on the opioid receptor. So a lot of the medications that Dr. Slattery had mentioned earlier, such as the benzodiazepines or other pain medications, naloxone will not be effective for. Additionally, it's important to note that CPR should be used instead of naloxone if an individual does not have a pulse. If they do not have a pulse, naloxone is unlikely to be beneficial, and CPR should be the first action performed. So how do we respond to someone who we do suspect is suffering an opioid overdose? First, we want you to take care of yourselves. Make sure you're using universal precautions. At a minimum level, this means medical gloves. We want to check the patient for responsiveness and administer initial rescue breaths if the person is not breathing. At this point, we want to make sure that we're getting help and you request further assistance. Here is the opportunity to administer naloxone. After we've administered naloxone, we're going to resume rescue breathing if the person is not breathing, and then we'll reassess for a response and administer a second dose of naloxone if there's no response after approximately 3 minutes. Now let's talk about how we actually administer the intranasal naloxone. First, we're going to prepare the kit. There are 3 components that are critical for this. First is a needleless syringe, you'll see on the left. Second is the medication capsule in the middle that actually contains the medication naloxone. And on the right, you'll see the mucosal atomization device, or MAD. This is a foam cone that's oftentimes shaped in triangle. It's white, and this will provide a fine mist of the medication to increase the medication absorbed within someone's nose. The first step is to remove the protective caps. Oftentimes the syringe has 2 caps, and the medication vial has 1 cap. The second step is to attach the mucosal atomization device, or MAD. This simply screws on to the syringe barrel using a twisting motion. And then third, we're going to gently screw the medication into the syringe itself. It's important not to screw too tightly or the medication will start to dispense from the mucosal atomization device. And then finally, we're going to administer 1/2 of the medication into each nostril, and you'll see on the syringe barrel itself there's markings that will show you when you've administered half the medication into one nostril, and then you'll move to the second nostril. And the medication does take approximately 30 seconds to a minute to work, at which time you may need to continue to provide rescue breathing. Finally, you're going to reassess them in about 3 minutes to see if the patient needs to be redosed with additional naloxone. At this point, we're going to watch a video. This video shows a scenario of someone approaching an individual with a suspected opioid overdose, and they take the steps necessary to administer intranasal naloxone. Naloxone intranasal spray should be considered for any suspected opioid overdose in which the person appears unconscious and is either not breathing or has slowed breathing. When you approach an individual, first check to see if they are easily awoken. Say their name and gently shake them. You can also apply a painful stimulus, such as a sternal rub. If they are unresponsive, check for breathing and a pulse. If they are not breathing and have no pulse, immediately begin CPR and assure EMS is en route. Do not give naloxone if there is no pulse. Focus on high-quality CPR until additional help arrives. If there is a pulse but the individual is not breathing or is showing signs of inadequate breathing, begin rescue breathing and administer naloxone. The supplies required for intranasal naloxone administration include 2 milligrams of naloxone medication, which is supplied in a medication vial, a plastic syringe barrel, and a mucosal atomization device, or MAD. First, you will need to prepare the naloxone for intranasal administration. Do not prepare it until you are immediately ready to administer it. First, remove the protective caps from the syringe barrel. Attach the atomizer device, which looks like a white cone, by twisting it onto the threaded portion of the syringe. Note, the other side of the syringe is open and contains a non-exposed needle to puncture the medication vial. After attaching the atomizer device, flip the syringe over. Remove the cap from the naloxone and medication vial and gently screw the medication vial into the syringe barrel. Do not prime or do a test dose prior to intranasal administration, as this wastes medication. Assure that the patient's head is tilted back so that the naloxone does not run out their nose, and instill 1/2 of the naloxone into one nostril. Then instill the remainder into the other nostril. After administering naloxone into both nostrils, resume rescue breathing until the naloxone begins to work and the individual begins to breathe normal again. Give the naloxone 3 minutes to work. If breathing is not restored, then give a second dose by preparing another intranasal naloxone syringe. Assure additional help is on the way. In addition to the kit that we showed you, which is perhaps the most common kit available for intranasal naloxone, you may see other formulations of naloxone administered prior to your arrival. On the left, you'll see that there are syringes. Naloxone can be given both through an IV itself as well as in through the muscle using a needle. On the right is a brand name Narcan intranasal spray. This looks different, but it follows the same principles that we just discussed using the syringe and the medication capsule. And on the bottom you'll see is an auto-injector that is a brand name that individuals can use to provide intramuscular injections prior to your arrival. There are two notable side effects to naloxone administration. The first is the most common, is precipitated opioid withdrawal. After naloxone administration, especially in individuals who have chronic exposure and tolerance to opioids, they may appear restless, irritable or violent, have body aches, feel dizzy, weak, have diarrhea, abdominal pain or cramping, nausea or vomiting, fever, sweating, goosebumps, and a high blood pressure or heart rate. Less commonly, patients may have an allergic reaction to the medication itself. And this will look like any allergic reaction that you may have seen before, such as a bee sting, where people have hives, difficulty breathing, and swelling of the face, lips, tongue, or throat.
Now we're going to look at some frequently asked questions. What should I expect once naloxone has reversed the overdose? Well, we expect improved breathing. That is the goal of naloxone administration, is to get the patient breathing. It is not to bring the patient back to being fully alert. We need them to be breathing. And there could be possible withdrawal symptoms. Can you administer it under the tongue? The lining of your mouth is not the same mucosal lining of your nose, so no, it will not be effective if you put it under the tongue. Does it work with a fentanyl patch? What about the newer fentanyl analogs? Yes, but be prepared to give a second dose. Fentanyl, especially the patch, those victims may need multiple naloxone doses. How do you store naloxone? It should ideally be stored at room temperature and away from light. If you're storing it in a vehicle, you want to store it in the coolest place possible, out of direct sunlight. You have now completed training for law enforcement on the safe and effective use of intranasal naloxone. Please familiarize yourself with your department's naloxone kit so that you are prepared and are comfortable with the kit prior to its administration. Thank you for your attention.